your patience. So yes, I'm Andi Orlowski, Director of the Health Economics Unit. I'm also Senior Advisor at NHS England, and I work at the World Bank as well as a Senior Advisor on Pop Health Management. A lot of my time is spent looking at inequalities work, and especially reallocating money to best meet inequalities and for prevention. And here is and I'll share some work we did across 5 ICSs on this topic. And so a lot of it is pop health. And again, I promise I will rush through this because I know that many of you will know this. So originally, when we did pop health management, it was all around having a defined budget with a defined geography. That never really happened. Only 2 ICBs are coterminous, and I think that's Gloucestershire and somewhere in the southwest. But I think something that we could all agree with, that pop health management is a evidence and analytical approach to population health to help better understand health needs, identify opportunities to improve quality, so we can then plan and reinvest or invest money, and then, of course, create learning health systems so we can monitor and evaluate, all for the triple aim of healthcare and to reduce inequalities. And of course, to remind you, so in the triple aim, so improved healthcare and an improved experience of healthcare and care, all at a lower cost. So better outcomes, a better experience at a lower cost. All of this will sound familiar to you because for the last 20 years that I've been in the NHS, we've been having white papers and reviews all the way from 2006 to the latest Darzi review, including a previous Darzi review, all saying that we should be reallocating money and having this left shift to look at prevention and helping to do more to help manage that. So how can we, analysts, people like you who really understand data, use data to help inform the decisions to make sure that we can bring to life things like the Hewitt Review, or now the Darzi Review and the 10-year plan. So a big part of what pop health management is still about, and again, the reasons that we're still chasing this is, as you know, we have an aging population, and a part of this is our total fertility rate in England is about 1.5, and in Scotland it's about 1.3. This is something that we at the World Bank are really interested in. So that means in a generation in England, we'll lose 25% of the population. And so this is why we're getting these big swings in the aging population. So, and for those of you really interested, places like South Korea and in Malta, the total fertility rates are below 1. So they will be losing over half of the population in a generation. So how do you fund healthcare? How do you manage all of this? It's really going to be a tough challenge. Multimorbidity is on the increase, and I'll talk a lot more about these wider determinants of health. And this is where we're looking at health, not just healthcare, and the impact that wider determinants have. And of course, we have financial and workforce challenges going forwards. So what did we do? We created these integrated care boards. So this is the idea that they would manage the population of about 1 to 3 million, and then we have subsections underneath that. So provider collaboratives, place partnerships, and neighbourhoods, and you may be working in those organisations. But all to do those things that we've already talked about is understand our population and create good population clusters and a real good understanding of this through segmentation. Move from reactive to proactive and reactive care. So looking at things like risk stratification, and we can talk about how risk strat doesn't work at the end, at the topic of my PhD, and focus of clinical needs for the personalised and participatory approach. These finding people who are amenable to change, impactable, which is a horrible American phrase, and this idea of coordinating and integrating care. So quick reminder, 80% of your health outcome comes from these wider determinants of health. So the NHS, in theory, only has an impact for the 20%. Your chances of having a stroke, surviving a stroke, the care that you get all the way through comes from the NHS, and the same for your COPD, etc. All of these other things like your health behaviours, your environment that you live in, and your social and economic factors have a profound impact on your health outcome, much bigger than clinical care. The one that the WHO works, I'm sorry this doesn't project well, but again, you will have all the slides, everything you need for the references. But one the WHO uses talks about how medical care only provides 11% or changes 11% of your health outcome. And in fact, your physical environment, your personal behaviour, social circumstances, and this includes your genetics and biology, have a much bigger, profound effect on healthcare. So a little reminder of why these wider determinants are important. So 20% of the population doesn't live in houses or dwellings that don't meet decent standards. And to give you what do we mean by decent standards? Heating. So 1 in 20 people don't have adequate heating in their homes. That leads to damp and mouldy homes. And you may remember a couple of years ago, someone in the Northwest who was known to the NHS, a young man in his late 20s, who was known to the NHS, so had been seeing his GP, taking his drugs for his COPD, had gone to A&E and had rescue steroids repeatedly. So we were caring for him, and it was a frequent flyer, as it's sometimes named. But a young man in his, late 20s died of COPD in England. And it wasn't because of the care we were providing in the NHS, again, that 20% of the outcome. It was because his flat was wet, damp and mouldy. And basically every time his rescue steroids wore off, he had another COPD exacerbation to the point where he ended passing away. So this is the impact that a warmer home would have had, and it would have been much cheaper to give him a warm home and get rid of the mold than it would have done for all of that care. 1 in 5 people live in poverty, and that's £135 a week in disposable income. So, and by disposable income, all they're counting there is you paying your rent or your mortgage. So for that £135, you have to pay for your clothes, food, travel, everything else is all part of that. And again, 20% of the population live in poverty. So particularly challenging. And children in deprived areas are 9 times less likely to have access to green space and places to play, which means that they end up playing in more dangerous areas, which lead to harm. And I include this last one mainly because I think many of you most probably have the highest levels of education. And did you know that you'll live 4 years longer than those without a degree or a master's or a PhD? And so just to say that I got my PhD after 30, so I don't think it counts for me. Life expectancy. And again, I'm sure you guys know this, a big difference between our poorest populations and our least deprived populations. But just to put it in a slightly different light, this means that men in our highest deprived areas live a quarter of their lives with disease. So a quarter of your life living with disease, and of course the costs associated with that. And if you're a woman, it's about a third of your life. So just over 30% of your life living with disease. So this is obviously a miserable place to be, living with a long-term condition that you'll have for the rest of your life, but 30% of your life within a disease. So again, managing our populations and better understanding them are really, really important. So, and this is a little bit of work we did with an integrated data set in London for the Health Foundation that just talks about this aging and morbidity. So we talked about how the population is changing. So are we just living longer with disease, or is the disease compressed at the end of our life? So we all have a big amount of cost burden, disease burden at the end of the year. And our work in Northwest London shows that it's actually a bit of both. And you have an expansion of morbidity, so you do live longer with disease, but you get this kind of hockey stick at the end of a really big ramping up in long-term conditions and disease at the end of life, or certainly if you live in Northwest London. So all of this is talking about how we need to move our proportion upstream to manage care upstream, and how important it is to do that. But as I say, we've been banging on about this for 20 years. And also reminding people that the high-risk individuals that we've done with risk strat and other bits of work are not to be conflated with those most likely to benefit. We've done some excellent risk strat models, great at identifying people at risk of an event or a negative outcome, but there's very little evidence to show that those people who have programs targeted at them, we actually change their outcomes. And again, we can talk about that at the end. So the topic of this was, so that's the background. We need to move more upstream. There's loads of different data sets that we should be looking at that look at these wider determinants of health, not just healthcare data. How can we help systems make the best possible decisions through this? And so, of course, we need to understand how systems do this. So ICBs were created to help bring together systems to make these changes. But sadly, there is little convincing evidence to suggest that the collaboration between local healthcare and non-healthcare organisations improves health outcomes. So the whole premise of ICBs, there's no big evidence base to lean back on or to look back on to suggest that we can make these changes for the better. And this is work from Hugh Alderwick from the Health Foundation, who's head of policy there. And he talks about the fact that people have different motivations and purposes. What success looks like for primary care in something like COPD may be very different to secondary care, may be very different to education, environment, local authorities, etc. So we all want something good for the patient, but what success looks like may be very different. So our vision and aims will be different. Our commitment to this will change. Governance and leadership's how we make the decisions, how those groups make decisions to agree on where to spend money is different. Resources and capability, and of course relationships and cultures, all because we've been told to work together doesn't mean that we will work closely together and manage things well. And there's another great paper by Unger who talks about, I very much like his use of the word faith, the idea that we don't have faith that the other people can deliver this. So rather than them deliver it, what we will do is we will deliver it ourselves and keep control of the money in the budget and make and that way we can withdraw it if we don't think it's working, because we don't have faith that the other people will do a good job, or we don't have faith that the program will deliver. But just to say, all of this seems like bad news, that systems won't work together and deliver it, but people have been doing this for a long time. So in Wakefield, the CCG before, this is ICBs, did some wonderful work with the housing debt team to stop homelessness. As you may know, people who are homeless die 30 years before the propensity score matched peers. So 30 years before this. And just to remind you that when we say homeless, I don't mean just people living on the street. When we talk about homeless, people living on the street is the very, very tip of the iceberg. The vast majority of people who are homeless are living in sheltered accommodation or accommodation that we have put them in, the NHS, local authority, social services, thinking that we're doing them a favour. Those people are still included in those statistics and still die 30 years before, on average, before their peers. And this is because they're exposed to crime, violence, drugs, and an environment that is not conducive to long-term health and care. So we need to do everything we can to keep them out of this, of being homeless. And so Wakefield used the housing debt team, community safe officers, etc., to help better manage hoarding, poor tenancy management, and beyond 150 people, 400 interactions, save 1.1 million. Not great shakes in the grand scheme of things. This isn't billions of pounds, but a significant amount of money and a good social return for everyone. Guys and Tommy's, the charity is, some of you may know, Guys and Tommy's, the charity is extremely wealthy, most probably has more money than the Health Foundation. It's one of the wealthiest hospital-led charities. They paid just 250,000 to the local authority to put in traffic calming measures around the hospital to reduce pollution and therefore stop exacerbations for COPD and asthma. And so relatively cheap thing, charity of the hospital supporting local authority to help with a social enterprise or social program. And my favourite is in the Northeast, there was a Gentoo, who are a housing association, did some work with Sunderland CCG in housing, in other housing associations, to install energy efficient boilers, double glazing on prescription and installation on prescription, and to reduce emergency admissions, A&E attendances, and GP appointments for COPD. So, and again, this is a huge benefit and changing the environment. And as you see, all of these are about changing personal behaviours or environment and social and economic circumstances that can have a profound effect above and beyond clinical care. So we started to use, to try and get ICBs to agree on how they should be tackling inequalities and how they should be moving money. And we chose COPD because COPD is part of the core 20+5, a great marker of inequalities, because it tends to be people who are exposed to certain jobs and levels of pollution that are often associated with deprivation, again, including smoking and beyond. But we used a tool called multi-criteria decision analysis. It's been around for decades. Many of you may know it well, but it's a decision-making tool that starts to help unpick some of those things that we talked about earlier in the Alderwick's paper, that is looking at trying to align things like motivation, mission and aims, the purpose and governance around things. So what it does, it starts to quantify these different criteria and start to weigh them. So this was famously used in California with the oil companies and the green activists on the decommissioning of oil rigs and everyone in between, on how they should decommission the oil rigs off the Californian coast. And how can you bring across two very polarized groups and come across? So hopefully it's not quite that polarized in our work, but MCDA is a great way of us being able to attribute a weight, and then to start to compare those criteria that people use to make decisions to be able to better understand what we should be doing about it. So we did some work in Birmingham and Solihull, Coventry, Northamptonshire, Nottingham and Gloucester. All of this is available online. I'll be able to share it at the end. But the idea was to use healthcare data and health data to better understand the care pathway for COPD and what people could be doing to reallocate some of the money, not all of the money, some of the money from this, to start to build a higher value pathway for patients. So it was done alongside, just to say, with support from the Midlands Decision Support Network, and I think Kevin was just mentioning something about that, who have been wonderful through this. And we also worked with the HFMA, the Healthcare Financial Management Association, on the approaches. So first of all, we did a discrete choice experiment with 500 COPD patients to better understand their preferences. And again, I'm sure you guys know about this approach, but we were looking at all these different elements that patients may find valuable. Do you want to see a named GP in 2 days or a GP today? Would you prefer to go and visit someone, someone who is close by or someone further away, but you could see them at different timescales? So all of these different choices were run through. 500 patients were seen. We've published that work, and or it's in publication now, and I'll be able to share it with you to better understand what the patients thought. We then did a massive literature review, and again, very happy to share all of the work that we did. That's also been sent out, been written up for publication. I'm looking at different interventions along the care pathway, and then we looked at loads of different data points, looking at the cost and activity of the different interventions, and I'll show those interventions that we did. And as I said, some of this data was very dirty. As you know, lots of stuff is still commissioned or since COVID have been pushed into block contracting. So where we could use patient level information costing, so PLICs, you don't need to have the pounds and pence, because we very deliberately used a system called STAR, which means that actually what you're doing is comparing the differences between things rather than the absolute pound. So if it's £17.22 versus £18.23, you can put it somewhere, you could just say 17 or 18, because really what you're doing is comparing £20 versus £100 versus £1,000 later on, and we can show how that's unpicked. We then did workshops with 22 people in this case, and this is Nottingham, the first one, which included patients and carers and people who lived experience, clinical specialists, public health, finance, informatics, analysts and transformation people. And then we modeled different pathways to come up with that, I think. And I'll just show, this is an output. And again, it may not look great on your screen. I promise you all of this is freely available. We'll be able to share you all the reports afterwards. But what you do is look at all of the interventions and you map them, and you create what they call this efficiency frontier. But what you're looking for is tall, spiky triangles and not low, slopey triangles. And I don't think it'll be a big surprise to anyone to see hospital admissions and things like lung reduction surgery in the far right, where things like primary care health checks and things that and prevention on the left. So we go through this work and better understand that care pathway, so you can start to pick out which of these areas do people see as valuable. And of course, what you may find out is that Nottingham patients, carers, clinicians may value something like, I don't know, primary prevention smoking cessation as more or less important than say someone in Gloucestershire, because of whatever cultural and different elements that may be there. So you have this view of the care pathway, and then at the end we came up with, working with patients, carers and the system, 5 interventions that they could focus on. So the whole point of allocative efficiency is to reduce money, or reduce spend, or spend the same amount but in different areas to improve the health outcome of the population. What we found in Nottingham is that they decided to spend more money because they used money for health inequalities to prop up some of the spend, and so they actually looked like they were going to spend up to nearly 900,000 more to try and improve the health gain, or the perceived health gain, by about 34%. For their population. And we did the same work again. I will race through this so we can get to questions, because I know I wasted a couple of minutes at the start. For Gloucestershire, where we had 28 people in the room this time, and we looked at their pathway models. And again, no surprise that hospital admission and lung reduction surgery are on the right-hand side, and no surprise that things like vaccination and primary care case management is on the left. And say it's an important way that, even though the data and lots of the things that we did were really key to better understand care, it was the journey to make the decision that was actually very, very important. So, and in Gloucestershire, they could save around £1 million and increase the value perceived to the population by about 12%. And in Birmingham, Solihull, we had 20 people. Birmingham Solihull, one of the highest deprived ICBs. I think around 50% of the population are in the bottom quintile when you look at deprivation. And so we did everything we could to try and get patients and carers in the room. And Birmingham Solihull, and again, we were working with the ICB to try and get those people in the room, but we struggled to get any representation from them. But even then, we still saw that hospital admission, and because you tend to think that the answer would be more medicalized because you didn't have patients, but we had hospital admissions, as you'd expect, on the right hand side, primary care, case management and vaccination on the left. And there they could save about 1.8 million and improve the percentage population by about 50%. And I will race through just to say Coventry, and again, all of this is free, so if you're from Coventry, I promise I'm not whizzing through, because it's you'll be able to get this at the end. And if we get, and also true for Northamptonshire. But what we saw across the 5 ICSs is that we could do maybe a total of £5 million worth of savings, and increase population health by 52% by taking activity data, attributing a cost to it, and using this multi-criteria decision analysis rather than anything else kind of going through to come out with an outcome. Yes, it's relatively small amounts of money, but again, the whole point of this is the small amounts of money are there because we're trying to build faith and trust in each other that this isn't going to be a big left shift that is damaging hospitals' income or whatever else it is. It's about moving relatively small, discrete amounts of money that you can then track and see the outcomes. All the links and stuff are on here for everything you've seen, and I will share this at the end as well. And you'll have these slides just so you know that you won't have to worry about it. But I will stop there.